So, Amina, finally we get to do this. Drugs and Coffee podcast. You're officially the first guest. And
Thank you.
well,
I'm honored.
yeah, no, thank you for accepting. It took a while to get us, to get our calendars, kind of synced, right? Because you're super busy
Yeah,
these days.
it's been a whirlwind, but glad we finally got to connect.
I know. I know. I mean, there are many things we can talk, and we'll explain why you're so busy very soon. So, um, first off, I just want to say who you are, what you do right now, where you come from. So, your name is Amina Abubakar. A lot of people know you in the pharmacy world. You're currently owner of RX Clinic Pharmacy. That's one. Then number two, you're with Avant Institute for Clinicians.
Yes.
That's going to be our major topic. And also, recently, you were with Troy Medicare, clinical director. Is that right?
Correct.
Okay, so you're busy.
Yes.
We most have one job, maybe two, but you have how many? Three? Okay.
Yes. For now.
For now, right? Okay. All right. So, can you start? Just tell us where you come from. What's your background? How did you end up where you are right now?
Sure. Well, I graduated from pharmacy school in 2005. And immediately after that, I took a community pharmacy position with CVS Pharmacy. And I did that for about 2 years. And then I moved into home infusion. And I did that partially working at home infusion and also at an independent pharmacy, the medicine shop. And then shortly after, in 2009, I opened my own pharmacy, RX Clinic Pharmacy, which makes 10 years this year.
Yeah, that's big. 10 years, right? They flew by.
Yes. Yes, just like yesterday.
I know. So, and what was the next step after that?
So during the pharmacy times, as I was running the pharmacy, so I always was passionate about clinical pharmacy and meeting patients where they are, counseling patients. So, my further background is I grew up in Kenya, and in the 90s, when I was growing up, HIV was a big epidemic, and there were a lot of deaths and complications from HIV care.
Mm-hmm.
So, I was fascinated and challenged myself to understand more about this disease state and how I could serve the patients who were going through both the emotional and physical trauma of the disease at that time. So I followed my passion, and during pharmacy school, I focused my rotations of infectious disease a lot on HIV. And as I started practicing, these were the patients, even during my CVS years, they gravitated towards me because I really wanted to learn more about how I could help them. So we connected. So our pharmacy for the past 10 years has really developed a niche with HIV care. And, we are a URAC accredited specialty pharmacy, which now we've diversified our disease states from beyond HIV because our patients are living longer. They have co-infections with maybe hepatitis, but then we're treating patients with rheumatoid and so on in terms of high complexity of our patient.
Mm-hmm.
So during this time, as passionately driven clinical pharmacist, I was trying to find it in the community. I knew that the hospital setting may give me a lot of this exposure, but I'm a community person. I didn't see myself uh, treating patients or working with patients that were just in the hospital for, at most a few days or weeks. I needed to know how they were doing once they went home. So I really knew that I belonged in the community. But the constraints of the corporate world
Mm-hmm.
weren't matching with my values. So that's when I took the chance to open the pharmacy and start building
And
my
that's a
own
big
clinical
step. I mean,
services.
just to kind of make that leap. I mean, a lot of people probably think about it. Maybe I want to open my pharmacy, but it's a big step to do that. It's not easy.
It is, and I think I just have a personality that I'm not afraid. So what if it didn't work? You know,
Well,
at least I know that I tried.
I
So
mean,
that's just
that
my
being said, and
attitude.
kind of, if you go back to your, kind of making that leap from Kenya. I mean, you made a lot of leaps, right? I mean, making that leap from
Yes,
Kenya to Virginia, right? That was your first
yes,
stop. I mean,
yes.
that's a big change too.
Yeah, there was a blind move, and then Virginia to Pennsylvania, Philadelphia, Pennsylvania. That was another leap of faith that worked out great, and then Philadelphia to Charlotte. So I'm just intrigued about change, and I think it does not make me uncomfortable.
Mm-hmm.
I'm used to I'm used to working in the gray zones. You know, when
Mm-hmm.
nothing is figured out, I'm okay with that. I
Right.
know a lot of people want to have the bridge built. You know, they want to have the policies and procedures already created so they could work from it. But I'm okay working with unknowns and figuring it out as I go.
So you kind of just have, okay, I want to make it from A to B, and I might not know how, but I'm going there, right? I'm just gonna
Yes.
head towards
Because
B and see if it
yes.
happens, right?
Yeah, so I stick with the theme. I may not know what and how I will do it, but I always know why.
Mm-hmm.
So because my why is clear, I'm always okay to figure out what it is I'll do and how I'll do it
Mm-hmm.
as I move along.
I mean, it makes sense. I mean, it explains a lot. So, I mean, it does. Growth is usually painful. So,
Oh,
just,
tell me about it.
I mean, I
I
know
wish
you
we
know.
actually,
So,
I wish sometimes we had body cams in the pharmacy and people could really see the meltdowns, the uncertainty, and the redrawing of a strategy
right.
constantly. You know, on the surface, it all looks done and good as we present nationally, but a lot of times I just wish people could see the journey
Mm-hmm.
behind the scenes to get to some of those finished products. It's exciting, but it can burn some free neurons in the brain.
No, I understand. So I mean, so you did the RX Clinic Pharmacy, and that took some time to figure it out what to do and what model to set up, and it's probably still
A
evolving.
work in progress and evolving.
Yeah.
So what was interesting as
Mm-hmm.
I was sharing why I was clinically driven and passionate and trying to make it in the community, what I didn't realize I was doing by working with these patients one on one and learning more about how I could help them, I always made notes to their providers. You know, what I found and what I think we could do
Mm-hmm.
to help the patient. What I didn't realize I was doing is I was building value, but I just thought I was doing what I was passionate about, you
Mm-hmm.
know. Hence the name RX Clinic was that every prescription was going to be thought of clinically. So when a patient enters with a prescription in our pharmacy, I had this vision that what what can we know more about this prescription?
Mm-hmm.
You know, why is the patient on this prescription? What happened to get them to this prescription? What are their goals? Do they even know? What are the goals that the provider has? You know, so I wanted to always reconcile what I learned in school based on the guidelines and what the providers thought and what the patients thought. So as I kept doing a lot of those that
Mm-hmm.
was beyond dispensing, I was building a network of providers that we became friends, you know, and
Mm-hmm.
they relied on some of my feedback for their patients. And then we moved from me faxing and calling the office to them saying, hey, Amina, here's my cell phone. If you ever have any questions about my patients, just text me,
Mm-hmm.
because sometimes it was taking them longer to respond. So then I said, oh, we've moved into a friend zone. This is awesome. So I was building this provider network. Now looking back, that's what I was doing. So 4 years into the business, let me say, yeah, 4 years into the business, I was getting overwhelmed. And of course, the demands of running the business and the demands of being a visionary, being an entrepreneur, and being the pharmacist was getting the best of me and not able to really serve the patients the way I wanted. So I made a leap of faith and hired a student who was on rotation with me twice. And she had now graduated, did a residency. That's Olivia Bentley. So I hired her to come on board because I felt like I needed to be freed, not to work in the business, but on the business. So that became my journey of really transforming our organization so I could step away and continue building the vision that I had. Because the daily activities of running the business was getting the best of me. Because it's exhausting. So when I brought Olivia on, I started now taking a step back, and I could clearly see the industry moving towards that direction. So I made a list of things that we will protect our business from being known as the product centered. You know? So what did we need to do? How can I take all those relationships that I had built with the providers for them to see that we're moving away from product centered? That's great. We can fill prescriptions for your patients, but now we're making it a standard that we will do kind of like a medication review or a quarterly medication therapy management, whether or not we were paid by their insurance. It was more for me to know how the patients were doing. So as we started doing this, then we got hit as the industry started declining in reimbursements of the product. So we were right on time into building these other services.
So you started early enough for you to be able to kind of figure out the first kind of, the problems that you run into. So
exactly. And again, for me, it was more because the why was clear. I wanted to be that community pharmacist.
Now let me stop you just for a second. I just want to,
Sure.
I had a question, something I kind of, as you were speaking, it came to me. When you were, you said when you were working in the pharmacy and you reach out to doctors about different questions about drugs and things like that. I mean, a lot of people feel kind of scared to call the doctor and tell them what they think and kind of make recommendations. And, that whole aspect of pharmacy, I mean, depends on the person, but a lot of people do feel kind of, we're not partnering with the physician. We're more just a little pharmacist in a pharmacy, just trying, to do something. So now, did you see a difference on how physicians respond to you when you when you work for a retail chain versus when you call from your own pharmacy, from independent?
Yes, interesting. Yes, interesting. And I think what has happened in our professions is that silos had been created, and there's a prejudgment, on pharmacists' intrusion into the medical world. And also looking back, I realized when I worked for a chain, nothing against them, but their rules really confined these relationships. So the pharmacists really never went out to even meet these providers,
Right.
So you didn't really build a human-to-human connection. So it's always this fax. They always know you by the name of your company. They don't really know who you are. And so the relationship is more based on transactional.
So when you had your own pharmacy and then you reach out as RX Clinic Pharmacy, Amina, then they have this kind of, okay, I'm dealing with somebody, like a human being on the other side who
Yes,
can.
and that is a natural way when you open your own pharmacy, you
Mhm.
have to meet who's around in your community. So I wasn't reaching to these providers on the phone. I first went and introduced myself. Hey, I'm Amina. I'm opening this pharmacy here, and these are my goals. This is what I'm looking to do in the community, and kind of learn more about them. Why did they get into business? Why
Mhm.
did they get into medical school? So naturally, I like to make friends. So I guess to me, that's a natural way of connecting. And I'm always curious as to how people ended up where they are. And so maybe that gave me even another layer of
Mhm.
building that human to human connection. So when I would call, I was calling as Amina. A lot of the providers, even patients, didn't even know the name of my pharmacy.
All
you
right.
know
It's just Amina, the
it
pharmacist.
was Amina's pharmacy. And so even when they would write a check, they would write Amina, and I'll say, no, you're right to RX Clinic Pharmacy. So I think that was the advantage I had of building relationships in the community.
Mm-hmm. Mm-hmm.
And so as I would call them, I wasn't a stranger. Number one, they knew my why, and they now were accepting these recommendations. And I wasn't coming from a company that I was bombarded. I only have 2 seconds to kind of make these recommendations. I really had time to think through,
Mm-hmm.
a patient case, and ask for more information, interview a patient. So I was not looking at a snapshot.
Mm-hmm.
When you're in a retail pharmacy, a lot of times we have constraint with time,
Mm-hmm.
and the patient doesn't give us enough information because there's less trust
Mm-hmm.
as well. And
Mm-hmm.
so you're always just making up a snapshot to make a recommendation. But for me, as a new patient was coming to my pharmacy, I was learning who they were,
Mm-hmm.
what they like to do and where did they move from. I moved from Kenya, by Virginia, by Philadelphia. So there was a lot of human to human connection is what I really believe
Yeah, I mean, you can
helped
connect
RX
with people on
Clinic.
many different things. I mean, just the fact that you're in
Yes.
Virginia and somebody say, "Oh, I was born in Virginia," or "My cousin lives in Virginia." I mean, just a million different
Yes, or
ways to
someone
connect.
just said, "Oh, I love watching the National Geographic."
Right.
So whatever that is, it's always finding beyond a transaction. A lot of times people go in and their focus is the bottom line, is the number of prescriptions, and they don't even know who they serve.
Mm-hmm.
So I've always believed in that fundamental, just knowing people who they are, and connecting in that level.
So you made
And
a lot
so
of
that
connections
helped us.
there. I mean, you kind of established yourself in the community.
Without knowing
Right.
that this would become very valuable later.
Right. And that kind of leads us to the next thing, right? The Avant
Yes.
Institute. How did that come about? I mean,
So as the industry started finally catching up, and they were narrow networks, they were now lower reimbursements, and there was a lot of stress on the product side. So as I had already started building things like diabetes education, we had already started building very robust medication therapy management. I found an opportunity. The more I was connected to these providers, I started to see similarities. They were starting to get decreased reimbursements. They were starting to get burnout. They were starting to get offers from health systems to buy them out. Like I was getting offers to sell to the big chains
mm-hmm.
because they kept saying, you can't survive on your own anymore. You have to sell. And so when I started seeing those similarities, I used them to dialogue. I used the providers to see how do they feel about this, the
Mm-hmm.
possibility of them not being independent anymore. And then as we compared, I realized one thing that was profound for me. Pharmacists, and especially primary care providers, have so much in common. They do not practice at the top of their license.
Mm-hmm.
So because some of those things that were creating a burden in the pharmacy, it was a lot of administrative things.
Mm-hmm.
And all the things that was creating a burden to the providers, again, it was these administrative things. Yet these two, I call them species for now, all they want to do is take care of their patients,
Right.
But the healthcare was transforming from fee-for-service to value-based, and no one really understood what that meant. Because a provider thinks I'm providing value by looking at my patient eye to eye, by touching my patient, by listening. But the administration or the healthcare reform was going to electronic medical records, document more, click on all these buttons, collect more information, which the providers didn't think it was useful.
Yeah.
So
That's
they would
just
ignore
the
it.
problem with the big systems, right? Just collect.
So they would ignore these things, and they would say, now I just want to listen to my patient, and I don't care about clicking on all these 100 measures that they're looking at or they're screening for. So then I started studying about what is value-based care. So while in that realm of studying about value-based care, I came up with an idea. So I told these providers, it looks like the things that you don't like to do is really an upgrade for me.
I see. Okay.
From counting pills, I would love to ask those questions. And I would love to screen patients for preventative care. But providers, you have to understand, they went to school to be healers. They're really about diagnostic. They're really about figuring out the acute problem of their patient and solving it. They're really not into preventative. They do the preventative, but it's not as igniting as diagnostic.
Right. I mean, they want to find a problem.
They want to find the problem and solve it. What's wrong with my patients? And if you think about it, no one goes to see their doctor because they're well.
Well, I mean,
everyone goes to see their doctor because
everybody waits to the last minute, If
You
they
know how
don't go
many
to
times
the ER.
I've missed my physical? How many times I've missed my physical?
Right.
Because
Yeah.
it's
It's
kind
true.
of like, I'll do it, but something else comes up. Let me move my physical. But when you're not feeling well, you don't move. That becomes your priority. So I started to understand how they're practicing, who comes to see them, and there's no way that they would have time to really jump into preventative care at the same time, because their appointments are being booked by patients who are not stable. They need to see them.
Right.
So I just thought to myself, why not experiment this? So that was our first provider, and it happened. I was on social media, and in searching about value-based care and what's changing, thanks to all this artificial intelligence that can send you more of what you're looking for. I got this article that talked about pharmacists performing annual wellness visits in Asheville at a health system called Mayhack, and it was published by UNC. So I read it and I was intrigued that there's something called annual wellness visits, and that when pharmacists were involved, they had over 700% increase in participation for patients. So I took this article, I sent it to Olivia, and I said, let's explore this. So the next morning, of course, we looked at it, and I went to the first provider. And I said, hey, Dr. So-and-so, I'm curious. I saw this article. It looks like pharmacists can do it. The difference is these pharmacists are hired within the system. So I understand about vertical integration. I wonder if we could do the same thing, but on a contractual basis. Like you own the practice, I own, my services, and you contract them, and you contract me. And this provider said, in a matter of fact, we are allowed to hire, lease, or contract an employee, or to contract anyone to do services that we can delegate to. So that became my first experiment. And it worked wonders because the provider felt so relieved that someone was actually sitting down with this patient and getting a 5 to 10 year care plan and looking at missed opportunities for the patient, who hasn't had their mammogram, who hasn't had their colonoscopy, interviewing a patient on their full risk assessment, looking at the
preventative
list
stuff.
But looking at the
up to
BS
that
list
point,
became
up to that
more
point,
meaningful.
Yeah, but up to that point,
You
who was
know,
doing that in the clinic? The nurses, right?
well,
I
it's a
mean, the
hit or
physician.
miss.
Yeah, hit or miss.
It's a hit or
If you think about
miss.
it, right?
If you have time, you'll do it.
Mm-hmm.
But if you have 500 patients, 1,000 patients, it wasn't consistent. So
Right.
that's where it started. And as we started doing that, fast forward, we became even deeper into those collaborations. So it was from one provider. Now we are in 12 different clinics in the Charlotte area. And that, as we were asked to speak around the country, it was intriguing other people,
Mm-hmm.
but they didn't know how to do it. And so they would call and say, hey, could I come and shadow you? Could I shadow your pharmacist?
Right.
And at first I was really giving and invited people to come in. But then our pharmacist said, you know what, Amina and Olivia, we know that you really want to save the profession, but it's actually more disruptive for us.
Right. Let us do our
Because the
work.
folks coming in, they're not shadowing, they're asking a lot of questions. That
Mm-hmm.
means there's a lot of background they don't have. They don't have how we got here. They don't really know more about this code. It's
Mm-hmm.
not about shadowing. I am teaching, and I don't have the ability to do that and have 20, 25 patients on my schedule. So that's when we're like, okay, what if we pooled our pharmacists specific times of the month and created a program like a mini boot camp, like a workshop, and we really went through the background, logistics, operations, everything, and then at the end have it simulated as if they were shadowing.
Mm-hmm.
Would that be helpful? So that's what brought us to Avant Institute.
And how long ago was this? When did you first start?
It makes it 2 years, end of this year.
Oh, okay.
And once we started doing that, we had a lot more success. And we decided intentionally it was going to be smaller classes.
Mm-hmm.
So people felt like they had one-on-one. Because what happens is we teach in large classes like a CE.
Mm-hmm.
You have to understand not everyone's story is the same. This one pharmacist might be the only pharmacist, and now they're trying to incorporate this service. Then you have someone that have a group of 20 in their organization, and someone who doesn't even have a pharmacy, and they want to start their services. So strategies are different for everyone.
Mm-hmm.
So we realized people would sit through these large classes and they would leave and still don't know how to implement.
Right. I mean,
so we thought if we're going to teach, we want people to be successful. So we'll take a smaller group, get them through it, help them personalize their own strategy. And we've seen more success that way.
Okay. So let's kind of dive a little bit deeper into that. I mean, the whole, all the services and things like that are being provided, because I know people probably think MTM, because that's kind of the past 5 years at least, it's been kind of the main focus on everybody on the MTM. But really for you, that falls into community care, like the core, just kind of the basics of what you do.
Yes, we divided our services in the pharmacy as 2 tracks.
Mm-hmm.
So we have a division that does community clinical, and this is where the pharmacists themselves can bill directly, can do these services themselves.
Mm-hmm.
And then we have the collaborative track, and this is more like the ambulatory care by collaboration. And this is where the pharmacist does the work, mm-hmm. and the prescribers bill for the work. So MTMs for us is mm-hmm. more of the core of every pharmacist should do it.
So the community, I just want to kind of make it very clear. So the community care group of services includes MTM, anything the pharmacist can bill.
Yeah, pharmacists are doing great consults, immunizations, travel health, immunization consults. You can do insulin pump training from manufacturers. You can do pharmacogenomic consults, diabetes self-management training or education. So there's enough that pharmacists can do. There's biohormone replacement consults. So yes, there's a lot the pharmacists can do beyond dispensing on their own.
Right.
With different point of care testing for screenings. And yeah, that's what we call community. And in community, we have the core, advanced, and expert. Just because you may need some background information or a certification to do more, but that technically every pharmacist should be able to do it.
Right. So that's one group of services, and then the collaborative care is when you partner with a physician. And
Yes.
Now, can you explain that piece as far as certifications? Do you need any kind of what are the requirements, if there are any requirements really to jump into this, or can anybody really do it? And what
pharmacist.
So what are the main concerns people usually have? I mean, what or kind of
the biggest concern is getting the collaborator,
or
right?
Mm-hmm.
Because if the providers have not seen you in that sense, where your recommendations make sense and you had built that relationships of beyond dispensing, because a lot of them are clueless about the education we've gone through, especially the older providers. Maybe newer providers are used to having pharmacists on their team, they are used to team-based care, but a lot of the older providers, as one provider told me, they were trained in a triangle. They're on top of the food chain and everyone else is in the bottom. So who are you, to send recommendations to me?
Right.
So that's why when I said before, things that I was doing in building relationships brought me closer to them, that they saw me in that realm. So a pharmacist who wants to enter that world of collaboration, there's a lot of opportunity. But you can now look at what are the things that are easy to get in. So I would say chronic care management, pharmacists we're always doing chronic care management. To me, it's an extender of an MTM, because an MTM is a point in time, right? We get to do one CMR a year, and that's all we get to do. But what happens after that MTM? Who follows the patient? Pharmacists can follow the patients, but who pays us? No one. So CCM to us was an extender of an MTM, because right now, if you do an MTM and a patient tells you all their goals and everything that they would like to do, it would be nice to follow them next month and the month after. So to me, chronic care management, every pharmacist can do it. And pharmacists bring a lot of value in chronic care management, because medication-related issues are huge in patients with
and a lot of pharmacists already do that. I mean, when you think about it, if you work if you have your store and you're very good with some of your customers, I mean, you get to hear stories and their problems every month, and you get to jump in and help, call the physician. Hey, so and so told me about this. Can you address this with them? I mean, that's pretty much.
It's already a natural. That's
there.
Why I said chronic care management is already there. And then you build on that when you do an annual wellness visit. This is a yearly, very extensive preventative care, questionnaire, getting immunization updates, getting full risk assessments, depression screenings, and a big portion of it is a med reconciliation, just to mention a few things. But that, to me, when pharmacists are involved, they provide a lot more value, because, for example, when nurses and medical assistants and nurse practitioners are all trained by the medical providers, so they all think the same.
Right.
A pharmacist brings a diversification in that clinical team. So we could all look at the patient, but everyone is going to come up with different goals. And if you combine this team together, the patient is a winner. And that's all I see in the collaboration. Because, for example, I was talking to an MA and I said, so when you're doing an annual wellness visit and you do a full risk assessment, what do you do with the information? And she said, well, I just let the doctor know what the answers were. But then when you as a pharmacist, I look at the beers list and I look at the drugs that could have contributed to that. And I look at solutions.
So you add
are we
another
going
layer to the information, right?
Yeah,
It's
so
not
it
just,
really adds
yeah,
value. It's not just a screener, but it's a screener who can have possible solutions, which ultimately decreases the burnout for the provider who has to have all answers.
So instead of, let's kind of reverse engineer. So you're a provider and you get this report from a screen, and it's just data, right? And
Yes.
but you're kind of putting out other fires, as and you miss things. But if you get a report from a pharmacist screen with another layer of information, which is potentially a recommendation that makes sense, and it's easily implemented, that's huge. That is really
Yeah.
huge.
Yep. And the pharmacist is not there to replace anyone in the clinic. It's actually to diversify their clinical team. So if we're going to enter value-based medicine and it's patient-centered models, then all hands on deck, because providers are going to get paid more if the patients actually improve.
Right.
And if the patients need to improve, medical decisions have to be made. For example, the biggest value we've brought to our practices is meeting goals of A1C for patients with diabetes or high blood pressure, because some of the medication recommendations were needed, dose optimizations. A lot of pharmacists, as soon as I look at a med list and I have access to labs, I look at renally adjustments of medications.
Right.
I look at liver adjustments of medication. So it's just a different set.
And for a pharmacist, especially for retail or a community pharmacy, for you to get a set of labs, that's huge. That's kind of, you never get that, so for you to be in a position where you can get that information easily, it's huge, because then you can really act on it versus, well, I don't know, you need to talk to your physician, versus, oh yeah, I do know, let me talk to your physician. It's kind of...
Yes, and that's the whole idea of breaking those silos,
right?
Because not one person can really help the patient anymore.
Yeah, it's complicated. Yeah. Now, looking into financial side of this, kind of the incentives and what really makes this possible as far as the doctor and his clinic, hiring another, clinician on board, not hiring, and essentially just having another.
Yeah, they could hire or contract. So what happens is as I said earlier, the providers, if you look at one provider, their probably capacity for the day is 25 patients, right, for the day. But if you look at who's on their schedule, these are patients that have to be seen by the provider. So how many patients could you add on their list for these kind of in-depth preventative visits? So what happens is Medicare has a revenue stream for them, but they don't have the capacity. So if you think about, at the same hour that they're seeing their patients who need them for diagnostic and adjustments and whatever it is that the patients need, the pharmacist is running a parallel population health schedule. So at every hour, there's more revenue in that practice. Right. And so even if they pay you out of those codes that you did, the clinic doesn't lose and the patients get tons of value.
So essentially, the physician gets paid because of the codes the service the pharmacist provided, just like a nurse or physician assistant.
It's a billable unit.
It's a billable unit, and then the provider would, in return, pay the pharmacist for the services.
It's a productivity-based payment.
Okay.
It's very similar to if you hire a nurse practitioner, if you hire a doctor. The only way you earn your keep is being able to see patients and build codes that can provide revenue.
Right.
Unlike in a pharmacy, you hire a pharmacist regardless if you do one script or 1,000.
Mm-hmm.
But in the medical world, they're relative value units. So in order for a practice to make money, they have to have billable units that generate revenue. So this is a very similar. So you're bringing in another clinician on board, and the rules allow for the provider to supervise this pharmacist and do these services, and then they can bill for those services, and then the pharmacist earns what they worked for.
Mm-hmm. Mm-hmm. And then, so that's the kind of the basics of the financial piece of this, right?
Yes.
And then the next level is really the kind of the contribution pharmacists have towards like the star ratings and just the general.
Yes.
So
the first level of income is your immediate ROI, right? For both the pharmacist and the provider. That they didn't come out of money out of their pocket, to pay you, and you were able to get paid for providing the service. So there's an immediate ROI for both parties. So then every year, providers who bill Medicare, and now it has increased to even commercial, it's a shared risk model. Whoever meets their quality measures, they get a bonus.
Yeah, value-based medicine, right?
Yeah, so it's a value-based medicine. So no providers are all paid the same. So for example, in 2017 was the first measurement year, and 2019, they received the feedback. So the way Medicare worked was 2017, all the work that you did in 2017, you submitted to Medicare by March 31st of 2018. Then they reviewed everything, and then on 2019, they gave you feedback. So there are providers who got -4% because they didn't meet the quality measures. So then 2018, they're receiving 2020, but their results already came in this year, and some providers got -5%. So it's -5 to +5. So every year it gets higher and higher.
So that's the range, ±5 reimbursement, right?
Yes, and then it goes to 7 and 9. And then if you have exceptional, you can get an additional 10% bonus. So if you prepare your practice for value-based, as hard as it may be, this is why collaboration with pharmacists brings that ROI later, that they help you get these patients at goal, and then the practice gets, and look at how beautiful this is. So let's say in 2020, you were going to bill 200,000. Regardless, right? But now you're either going to get -5 or you're going to get +5 to that.
Right.
For doing the same work. So why not set your clinic up for that success? Because that's available.
Yeah, I mean, it makes sense. I mean, and not to talk, not to even say, I mean, if you set up a system in place that works, is just going to keep bringing, if you made +5 this year, chances are you're probably going to do at least that next year. I mean,
yeah, exactly.
So you have a good system in place.
And it brings a lot of value to the patient, to the payers. So it's really a true break the silos. Let's all work together. That's what value-based medicine is for me.
Okay, so right now, you have a network really of kind of clinics that you work with, and generally, what's the feedback? I mean, and you have pharmacists that work there. I mean, I'm assuming they're happy with it. I probably would be. I mean, as a clinician, you probably want a situation like that. So, kind of tell me a little bit about that. What's happening right now.
No, it's rewarding for both parties. A lot of the pharmacists that work at RX Clinic have been my students on rotation or our residents. So watching them get into this space, work hard to create the systems that then create their own jobs is very rewarding for them. in a time where pharmacy doesn't have the best light being shed on, and there's a lot of negativity around the profession. But to watch our team just grow from students on rotation, some residents, do these projects that come back and create their own jobs, it's been really good. Mm-hmm. At the same time, feedback from the patients, some of the patients wants to see the pharmacist again, mm-hmm. because they're having that additional individual that can pay them attention. Mm-hmm. And when you're talking about a Medicare population, by the way, loneliness is the number one social determinant of health. So having an additional person who wants to talk to you, who cares about your full risk, who cares that you're not depressed, on top of your doctor, a lot of patients have felt that their doctors are even amazing for bringing us on board to mm-hmm. help them. Mm-hmm. Mm-hmm. They would say things like, wow, I knew he cared, but wow, he cared enough to bring you in so you have more time to talk to us. This is really awesome. Right. So for patient-wise, this is great. And then for provider, I believe, and they share, because, I hope you can get to interview some of our providers, we've decreased their burden, mm-hmm. because a lot of times we're the filter mm-hmm. between the MAs, the nurses. They will show the pharmacist, hey, does this really require prior authorization? Is there an alternative to this before I call this insurance company so I don't bother the provider? Mm-hmm, mm-hmm. And so the pharmacists are able to help with some of those things and only escalate to the provider what requires their license to think through. But a lot of things we've been able to just work as a team, and that has been less and less of a burden on the main providers.
I mean, it sounds very rewarding and efficient. I mean, a lot of things, that pharmacists can do as far as medication in the clinic. I mean,
yes, absolutely. It's the future. It is the future.
Well, it's the present. We just need to make sure it becomes more widely available. So
that's why we teach, because we realize just within the Charlotte area, we can't even serve all the patients in the clinics we're in, Right. So there's so much there's so much that we all can do together, and I really think it would create more jobs for pharmacists, decrease physician burnout, give us outcomes, and be part of a very happy, healthy ecosystem of healthcare.
Well, everything sounds great. I'm glad we had a chance to talk. I mean, this is very positive. I mean, especially in this kind of environment right now, with a lot of negativity around pharmacy, a lot of people aren't happy with their jobs, and they kind of, I even hear people, oh, don't go to pharmacy school, don't do this. I mean, that just, to me, it doesn't make sense, given the training you get and the value you can give. So it just needs a different perspective, the different approach. And this is one Absolutely. Of them. So it makes sense. Thank you for being the first guest of Drugs and Coffee podcast. We're going to have more guests with a lot of similar topics, and hopefully more on this topic. So if people want to hear about you, they want to find out about Avant Institute, how did they do that? Where did they go?
Yes, they can contact on they can go to our website, www.avantinstitute.com, mm-hmm. or they can email us at info@avantinstitute.com. And what we've done, just to help the profession keep shedding some light, if you open a free account on Avant Institute, we have a series of free webinars that are introducing this dialogue and these concepts to pharmacists. Mm-hmm. And these are free webinars for you to start exploring how you fit into the new health systems.
Excellent. Well, thank you, and we'll stay in touch. Hopefully we have another interview. I think there are many topics we can cover, so we'll stay in touch.
My pleasure. Thank you.
Thanks, Amina.